The case is a 9-year-old boy with an incomplete Tessier midline facial cleft who now presented for operation. His examination was notable for hypertelorism. The patient reported no vision in his right eye at baseline. Imaging confirmed no intracranial involvement, and no additional craniofacial anomalies were identified. The prognosis for this patient includes a midline soft tissue cleft with an adequate vestibule, hypertelorism with a broad nasal base, widened pupils requiring ADA-based correction, a supernumerary tooth with a bony alveolar bridge. How would you face this case? Option A, mucosal diastroplasty and V-wire flap. Option B, a bilateral cheilorhinoplasty. The votes are in, and you chose B.
Hi, I'm Dr. Daniela Tanikawa from São Paulo, Brazil, and I'm pleased to discuss this very interesting article entitled Bilateral Cheilorhinoplasty Techniques may be applied to an incomplete rare facial cleft. This case presents a 9-year-old boy with an incomplete Tessier 0 cleft, an intermediate presentation that requires an atom-driven approach. As described by the authors, the patient presents with a midline soft tissue cleft with muscular discontinuity but preserved prolabial tissue, associated with a widened philtrum, limited vestibular depth, and a broad nasal base. Altogether, this configuration resembles a bilateral cleft lip pattern. In this context, the author's decision to use a bilateral cheilorhinoplasty is well supported, as it allows simultaneous correction of the lip and the nose with a balanced result. In my own practice, I would follow a similar pathway, addressing both components in the same setting. For the lip, I would use a bilateral framework with refinements inspired by Chong's marking strategy to better align the repair with the natural lips to be units and avoid a horizontal scar at the alar base. For the nasal component, I would also favor a primary approach. Using a modified Tajima axis allows direct visualization of the lower lateral cartilages, facilitating their repositioning and approximation, and improving the columellar relationship, particularly when wider. It is also important to recognize that these deformities exist along a spectrum. In cases with a true midline defect involving the prolabial tissue, often associated with a bifid nose, techniques such as mucosal Z-plast or V-wire flap, combined with a nasal approach, may be more appropriate. Overall, this case illustrated how bilateral cleft principles can be adapted when the anatomy is supported. The authors achieved an excellent result, reinforcing the importance of individualized planning. Thank you to the authors for sharing this case. And don't forget to read more interesting case reports every month on PRS Global Open. We see you next time on PRS Global Open Face the Case.